My name is Adam Leventhal, and I am the director of the USC Institute for Addiction Science. And our institute focuses on transdisciplinary research, education, and community engagement. And what we do is we bring together scholars and professionals from all sorts of different backgrounds across the University of Southern California and other areas to collaborate. And as part of our mission, we want to educate the public and educate our field. And so we have a distinguished speaker series, which is what you are here for today. And I am very, very pleased to introduce Dr. Jermaine Jones. He's an associate professor of clinical neurobiology and very, very well known for his work on the etiology of addiction and also novel mechanisms and targets for medications for substance use disorder. So a little background about Jermaine is, so he's a behavioral and neuroscientist through and through. It looks like he double majored, just checking out his CV now, but double majored in psychology and biology at the University of Virginia. He got his master's in biological psychology at Old Dominion University, and then a PhD in behavior at American University. And he did some postdoctoral training at Columbia University and stayed on and has risen up the ranks and is currently an associate professor of clinical neurobiology in the Department of Psychiatry. Well, Jermaine has won a number of different types of awards within the addiction science field. Most notably, he is a fellow of the American Psychological Association Division on Psychopharmacology and Substance Use, Young Investigator Award from the International Society of Addiction Medicine, and a slew of other awards. He's published more than 50 papers, has been awarded millions of dollars from the National Institutes of Health to support his work. And he also has an interest and passion, not only for research, but also for community service and engagement in the area of HIV prevention and harm reduction for people with drug use problems. So with that, I will stop and happy to announce Dr. Jermaine Jones. Take it away. You're muted, Jermaine. Oh, Reed, can you please release his mute?
Yes, sorry about that. One moment.
All right. Either that or he's really good at doing mime impression. I don't know. There we go.
All right. Thank you guys for, everyone can hear me. If I start coming in and out, someone shoot me a message in the chat. I can probably go a bit downstairs and get a bit of better reception. The view's just better up here, so.
This is good.
Okay. So I'm here to tell you guys about a series of studies we did at Columbia. It was one of the first few studies that I worked on as a postdoc and then junior faculty at Columbia. And it involved looking at medications that alter glial targets and treating opioid use disorder. So just a bit of housekeeping. I don't have any conflicts to report. Here's my current research, and these studies were funded by 2 grants from NIDA. One was an older center grant that our division had, and one was an R1 to Dr. Sandy Comer. All right, so I won't bother to go through telling you all the significance of the current opioid crisis and the need for medications to help those suffering from opioid use disorder. And furthermore, I won't go into the same statistics that you probably heard 1,000 times. But one thing that is interesting, if you don't know, is that we do have data from 2019 as far as opioid-related overdose deaths. And it looks like after going down for a few years, we're starting to get an uptick. And I imagine, given what's going on with COVID and sort of the isolation with people with opioid use disorder this year. So new medications for substance use disorder was one of the Department of Health and Human Services. It was a part of their 5-point strategy to address the opioid crisis. So better research, also looking into novel pharmacotherapies for opioid overdose, better understanding of substance use disorders and its etiology, getting more timely data on overdose. So there is still very much an interest in continued medications. Why do we need new pharmacotherapies? We have 3. They actually work really well, although retention rates at 6 months are still pretty poor. I think it'll be very interesting once we start to get some of the data on the newer formulations of buprenorphine. But for right now, despite having methadone, buprenorphine, and naltrexone, compliance and retention and treatment is still pretty unsatisfactory to smoking, in that I don't think there are never enough treatment options. So for smoking, there's 7 FDA-approved medications. There's 2 pharmacotherapies and the various forms of nicotine replacement therapy, and yet continuous abstinence rates remain pretty low. And smoking is still a significant public health menace. Given the need for focus on new mechanisms of treating opioid use disorder, NIDA recently, or maybe about 2 years or so, released their medication development priorities. I'm not going to talk to you about any of these. And there was a time when NIDA was very much interested in the glial modulators and the glial story and funding grant mechanisms. And I do think there might be, some continued interest in that. However, this is what they've and after the end of my talk, you may realize why they aren't that interested in glial modulators anymore. But I'm still interested in them. All right, so all of the mechanisms that I showed you previously were actually neuronal mechanisms, and I think it's really interesting that this new role, recent role that, this new discovery that glial are actually much more involved in neuronal processes and important to central nervous system function than we previously thought. Originally glial means glue, which was thought to reflect their function as being really passive players and just holding neurons together. But I think the importance of glial with respect to CNS function really gave them a new possible treatments for opioid use disorder. So the data that I'm going to tell you really focus on astrocytes and microglia. They're the primary components of the brain immune system, and most of the medications that I'm going to be tell you about alter astrocytes and microglia in some way, even though there's a ton of different glia and a ton of different mechanisms affect the CNS as a whole. So it's a really broad, with a broad area of potential investigation. So we've been studying the interaction between opioids and glia for actually quite a while. It was in 1979 that they actually identified that morphine and the endogenous opioid receptor methamphetamine modulate function of the human T cells. They also found evidence of receptors for opioids on immune cells. We know that glia and opioid receptor subtypes and the mRNA that encode them. I found citations that showed that as far as mu opioid receptor expression, it's 2 to 9%, delta 5%, and it's been observed for kappa, even though I wasn't able to find a reference showing how much it actually accounts for. Opioid peptides are also synthesized in glia, though there's very little known about storage and release from glia. So we know that acute administration of morphine increases the expression of cellular markers associated with glial activation. On microglia, that's CD11B. For astrocytes, that's also GFAP. Morphine increases the expression of glial cell signaling molecules, cytokines, pro-inflammatory cytokines, and chemokines as well. Morphine also enhances microglial migration, and apoptosis. So most of what I'm telling you about is preclinical studies, and in a lot of preclinical studies, morphine is really thought of as like the prototypic opioid. And so a lot of that work has been done with morphine. So even though I just told you that glial express the opioid receptor, the main effects of opioids on glia is actually thought to occur through this toll-like 4 receptor, the TLR4 receptor. And it's been shown that a wide range of cause activation of neuroimmune signaling through this TLR4 receptor. And so they demonstrated that positive stereoisomers of methadone and morphine actually don't bind well to classic opioid receptors, but they will bind to the TLR4 receptors. So these positive isomers actually have been shown to be, which don't bind to the classic opioid receptors, but do bind to TLR4, have been shown to cause the upregulation of pro-inflammatory cytokines that you actually don't see with just the effects on classical opioid receptors. Found that so there's the challenge studies, which I just mentioned, but also it's been shown in genetic knockouts. Well, if you knock out the TLR4 receptor, or the complex that it makes with MD2, you actually don't get the morphine-induced neuroinflammatory signaling that I showed you in the last slide. So what's really interesting is that these opioid effects mediated through the TLR4 receptor are responsible for opioid. For knockout mice actually show impaired development of morphine and oxycodone condition-place preference. So condition-place preference is just a preclinical paradigm where you pair an environment with drug administration, and then when you allow the animal to have sort of free reign in that environment, the amount of time, if they spend more time in the drug-paired chamber or the drug-paired area of the testing apparatus, then that's thought to be an indicator of a rewarding effect of the drug. Positive naloxone also blocks morphine CPP, and remember, positive naloxone isn't going to have an effect on the classic opioid receptor, just the TLR4 receptor. Positive naloxone also suppresses remifentanil self-administration, and I believe this is also in rodents, but I think there's a primate study as well. And positive naltrexone blocks cue-induced reinstatement of heroin self-administration. In a really interesting study by this group in Australia, what they did was they co-administered morphine with the pro-inflammatory markers of astrocytes. So when astrocytes, the pro-inflammatory signaling molecules from astrocytes, and when you co-administer those two, you actually get an enhancement of morphine CPP, which is just further demonstration that activation of opioid effects through TLR4 contribute significantly to the. So there's been a number of preclinical studies that have looked at medications that alter glial activity as possible treatments for opioid use disorder. And so what I have here is showing those medications based on the mechanism of action, and also the pharmacodynamic effect rewards, such as CPP, reinforcing effects like drug self-administration, paradigms such as craving and relapse, and also physiological opioid dependence. So in our lab, we followed up with studies. We followed up on these preclinical studies with proof of concept clinical trials with minocycline, pioglitazone, and abutolast. I'll only tell you about abutolast and pioglitazone just for the sake of time. So if you're wondering about the type of work we do, we typically do proof of concept clinical laboratory studies. So we collect 2 trials. They're typically done in a smaller number of participants. Our studies are normally inpatient. They're typically done among non-treatment seeking opioid users, because for our studies, we essentially try to model a lot of those preclinical paradigms in which we administered opioids, intravenous heroin, intranasal oxycodone to participants to then see how the medication or maintenance on the medication affects rewarding effects, subjective effects, drug self-administration, essentially the same paradigms that you would do in preclinical models. So in the clinical laboratory, the most common measure of reward that we use is self-reported subjective effects. So after participants receive a challenge opioid, let's say it's intranasal oxycodone, a 100 millimeter line appears on the screen that says how much of a good drug effect do you feel, and participant will indicate somewhere on that scale how much they agree with that statement above. I'll also talk to you about some cue reactivity paradigms that we use, and in one of the studies we do drug self-administration. So the idea behind studying rewarding and reinforcing is that initial drug use, there's an intoxicant effect to opioids, something that the individual enjoys about them that leads to initial use, repeatedly. Here, where we're trying to stop the prevention, to prevent the development of opioid use disorder by seeing if a medication can block those initial intoxicant effects of an opioid. So the first study I'm going to tell you about is with pioglitazone. So pioglitazone is FDA approved for the treatment of type 2 diabetes. PPAR agonists have been shown to inhibit the expression of pro-inflammatory monocytes, macrophages, and have similar effects on microglia. Some of the interesting preclinical work we wanted to follow up on was data showing that pioglitazone attenuated opioid withdrawal, heroin self-administration, and also heroin-induced dopamine release. So this first study that I'm going to tell you about, we conducted, it was an outpatient subject study within subjects design conducted among very light prescription opioid users, non-dependent individuals who had some history of non-medical opioid use. So the study, it was a within subjects design. Participants were maintained on 3 different doses of pioglitazone. It wasn't a randomized study, so about 14 days on a placebo, and transition 14 days on 15 milligrams and then 45 milligrams. At the end of those 3 maintenance periods, participants completed a testing session in which we looked at the acute effects of a dose of pioglitazone and also the effects of the previous 2 or so weeks of pioglitazone maintenance. During the challenge session, they received an oral dose of oxycodone. We did a cumulative dosing for this study in which participants received 0 milligrams, so the reason for this design, it wasn't a randomized design because, again, we're restricted to, so we essentially don't know the effects of pioglitazone on glia, and the extent to which what might be the necessary washout period between doses. Also, for this type of very exploratory first-in-humans investigation, we really wanted to effect. And so that was why we did this non-randomized 0, 15, then 45 milligrams, because at the end of the testing session, participants would have been on active pioglitazone for almost 30 or so days. So for this type of trial, we didn't want to end up throwing the baby out with the bathwater. So not the strongest of designs, but and the idea behind the participant selection was that if we possibly, the indication would be combining pioglitazone with oxycodone, and among these individuals who might be using recreationally, And if the dose, and you would still get the analgesic effects of oxycodone, of course, but then you can reduce or attenuate the abuse potential, then you have a medication that has, that's less likely to be diverted. So this is just what the testing schedule would have looked like for participants. So participants came in on a daily basis, received the dose from the nurse. They went home. At the end of the session, they conducted, at the end of that maintenance period, they received, they completed the testing session, pioglitazone plus oxycodone, 30 milligrams, maintenance, testing session, maintenance, and testing session. This will probably make more sense as I show you the data as well. So this is what these 17 participants looked like. Mostly male, polydrug users for the most part, some sporadic cocaine use, all had some experience with prescription opioids non-medically. It was required. Light marijuana users as well as drinkers as well. So this is what the data look like. So here is our mean rating of drug liking. So this scale goes, like I said, from 0 to 100, and they rate where they see how much they agree with how much do you like the drug that we gave you. So participants came in, we did baseline assessments, and they received their dose of pioglitazone. Then we followed up with a placebo dose of oxycodone, then a 10 milligram dose of oxycodone, and a 20 milligrams. So the cumulative dose was about 30 milligrams. And as you can see from the data over the course 6 hours of the testing session, there is a dose effect of oxycodone. With increasing oxycodone dose, ratings of drug liking increase. However, what we aren't seeing is a pioglitazone by oxycodone dose effect. Those three different groups are essentially right on top of each other, and there's not a lot of deviation between the two, or between the three. Participants did not report any significant aversive effects related to oxycodone or pioglitazone. We looked at physiological effects. So pupil size we do as a subjective indicator of mu opioid receptor activation. So as opioids decrease pupil size. So dose-dependent decrease in pupil size, but again, no pioglitazone by oxycodone action, and the same with plasma oxycodone levels. A dose-dependent effect, pioglitazone had no effect. So what we concluded from this study is that pioglitazone did not alter the physiological effects of oxycodone, nor did pioglitazone alter the abuse potential of oxycodone. I'm not certain how we want to do questions. Did we want to allow for questions after each study, or just at the end?
I think what we'll do is we'll wait to the end. We'll let you get through, and then people can enter their questions at any time into the Q&A function. So that way you don't forget, right? If you have a burning question, and then we'll cycle back. How's that sound?
Yeah, that's perfect. So the next study that I'll tell you about was another study with pioglitazone. It was an inpatient study between subjects design. For the study, we used opioid-dependent individuals who primarily used heroin. They were maintained on pioglitazone, placebo, or the high dose from the last study for about 3 weeks prior to conducting a testing session where they received either intravenous or intranasal heroin, depending on how they used on the street. So intranasal users got intranasal heroin, intravenous users got intravenous heroin during the testing session. So these participants, we made that decision because among this sample, we didn't believe that pioglitazone, and also based on the previous data, that pioglitazone wasn't going to be, a standalone medication, but it might be useful in combination with another medication like buprenorphine. So it was about a 3-week study. We had 30 completers. So instead of showing you the testing schedule as a whole, what I thought I would show you is the testing session that occurred at the end of the 3-week maintenance period. So we start off with baseline assessments, pupil diameter. The DAT and DSST are just 2 cognitive tasks. SALS, subjective opioid withdrawal scale, clinical opioid withdrawal scales. We have a visual analog scale battery of about 20 different assessments, 20 different measures, drug liking, good drug effect, bad drug effect, stimulated. It's a whole complement that we ask participants. So when we do our drug self-administration, we typically do a sample and then a choice self-administration procedure. So during the sample session, participants receive both reinforcers that we're going to ask them to choose from later. So that's what happens at time 0. So let's say I'm an intranasal user. A doctor is going to come in with 40 milligrams of heroin and say, here, I need you to snort this within 30 seconds in both nostrils, in one or both nostrils. They also receive our alternative reinforcer, which is $20. So someone hands them the $20 bill. So they experience both of the reinforcers. For the next 90 minutes or so, we do our battery of subjective effects. DEQ is another subjective effects battery, just to quantify how the drug made them feel. Later that around 10 a.m., and I'd say this is around 2 p.m. or so. So later that day, we bring them back down into the lab and they complete a Q exposure session. During the Q exposure session, participants are exposed to a neutral Q, and neutral Q is just manipulating a water bottle for about 30 seconds. And the drug Q for intranasal participants, it's pretty provocative. They have to prepare a powder for insufflation, roll up a dollar bill, and hold the powder and the dollar bill or the straw for about 30 seconds. For our intravenous users, they actually have to use this placebo powder and cook it, draw it into a syringe, and then hold the syringe for about 30 seconds. So after complete the Q session, they complete the choice portion of the self-administration procedure. That's when we say, hey, do you remember that drug we had you earlier in the day? You can now work to receive more of that drug, or you can earn more money. Let's see. So our self-administration procedure is normally 10 trials. So participants have the option of choosing drug and money at each trial. Each time they make a choice, the operant requirement, which is just clicks on a mouse, increases for that option. So if the first time they choose drug, they have to make 50 responses. If they choose drug again, they have to make 100, then 200, then 400, then 800, so on. If they, at any point, they can switch to between the reinforcers. If they switch to money, then money starts again at 50. So let's say at the end of the self-administration procedure, the participant has chosen 7 units of drug and 3 units of money. That would mean the break point for the drug would be about 1,600 responses and about 200 for money. That means also that the participant has earned a certain, essentially 70% of the drug that they sampled. So the physician comes back in with, if it was 10 milligrams of IV heroin that they initially sorted, then he comes in with 7 milligrams, and they actually would receive that dose at the time. And they would receive their money, which would be $6 or 30% of the $20. So this is what the participants looked like. Again, this was a between subjects design. 16 in the placebo group, 14 in the active, about 45 years of age, again, mostly male. Participants are using between 6 to 7 bags of heroin a day. In New York, that's probably spending between $60 to $70 a day on heroin. They've been using between 18 and 12 years. And the breakdown of intranasal and intravenous users was similar between the two groups. So what I'm going to show you first is the response from the Q session. Galvanic skin response, of course, increases significantly with active Q versus neutral Q, and also a slight increase in craving for heroin. But again, no effect of pioglitazone. So what I'm going to show you now is subjective reports of heroin craving. This was measured in the 4 days leading up to the session. So if you think of always occurring on a Friday, this is Monday, Tuesday, Wednesday, and then Thursday. So we didn't do the testing session on that day, on each of those days, but we did ask them like sort of how they were feeling during the run up to the testing day. So nothing significant there, trending. However, when we ask them how much do you want heroin, there is a slightly lower degree of heroin craving on day 5 with the in-participants maintained on active pioglitazone. So again, this is how anxious do they feel on the days leading up. Approaching significance at a few of these days, but on day 4, there are a few time points in that testing session where it was significantly lower for participants who were maintained on active pioglitazone. And this is just drug liking from the session. I believe there should be an asterisk here indicating significant difference. Nothing to write home about, but there is an effect at this time point here. And I'll move this. And similar for VAS measure of good drug effect, just at that last time point that it was assessed on that Friday. This is the drug self-administration, active versus placebo, and again, it's pretty obvious. The self-administration of heroin didn't vary, but as a function of pioglitazone maintenance. Conclusions, pioglitazone failed to alter the reinforcing or positive subjective effects of heroin, but there was a bit of effect on craving and overall anxiety. The next 2 studies that I'm going to tell you about were with a drug, Opioid, and it changed names a few different times over the course of the series of studies that we did with it. Opioid is a non-selective PDE inhibitor. It also inhibits TNF-alpha. In preclinical studies, the co-administration of Opioid with morphine significantly attenuated morphine-induced dopamine release within the reward pathway. Opioid also reduced the signs of opioid withdrawal in rodents. So the first study that I'm going to tell you about followed up on the possible indication for opioid. So when we conducted the study, there was no lofexidine, so there were no medications specifically designated to treat opioid withdrawal. So it was a really interesting indication, interesting and possible novel indication at the time. So this was led by Ziva Cooper to evaluate the ability of Opioid to reduce opioid withdrawal symptoms. So it was a between subjects, inpatient opioid-dependent sample without chronic pain. So I will go through the design with you very briefly. So for this study, it was about a 3-week study. Heroin users are transitioned from their street drug use onto 30 milligrams of morphine given 4 times a day, so 120 milligrams total during the first week of stabilization. They're also on a placebo oral abutolast maintenance. When we assess for withdrawal during that time as our primary endpoint. During the second week, participants are still maintained on morphine, and then they are randomized to one of these 3 abutolast conditions. Again, primary outcomes are withdrawal. During the third week, we switch out their morphine for placebo, and they are continued maintenance on their condition of abutolast. And again, primary outcome is withdrawal. So what the participants look like in the 3 groups, about 10 or exactly 10 in each group. Again, mostly male, between late 30s, spending about $50 to $60 on heroin a day, and they've been using between 13 and 15 years. And a similar breakdown of intravenous and intranasal users. So this is what the data look like for their subjective opioid withdrawal scale ratings. So this is the first week. Everyone's on more bit of withdrawal, which makes sense. They're still getting stabilized. It's the first week. So there are some withdrawal symptoms reported. That second week, everyone is pretty much very comfortable. We found that about 7 days of stabilization is sufficient prior to fentanyl being in everything. The second week, like I said, everyone's comfortable. The third week is when we switched out their morphine for placebo. So everyone's going through withdrawal, and no one's comfortable, and no one's happy with us. There is a bit of, so in comparison to the first 2 weeks, withdrawal significantly increases. However, this difference between the active and placebo conditions is still it's not statistically significant, even though it looks very promising. So what we did was we looked at the individual symptoms that are reported on the SAL scale. And when we look at those individual symptoms, we do see some statistical significance in the difference between active versus placebo abutolast conditions. So particularly stomach cramps, sweating, and also hot and cold flashes. So from this, we concluded that AB411 reduced opioid withdrawal symptoms. Oh, sorry, and that was it. Sorry, I thought I had more bullets there. Dr. Metz led this next study, following up on that other interesting preclinical study, which was showing that it reduced a dopamine release in response to heroin. So we wanted to look at subjective and reinforcing effects. So we examined the influence of abutolast on the subjective and reinforcing effects of oral oxycodone in detoxed opioid-dependent volunteers. So this was a randomized, placebo-controlled crossover trial. So because it was a crossover trial, I'll show you how the design works. So this is for participants who were first randomized to active and then transitioned to placebo. So there was a morphine taper, so everyone detoxes that first 10 days. Then they're stabilized on a 50 milligram dose of abutolast. They complete individual testing sessions with 0, 15, and 30 milligrams of oral oxycodone. They're spaced about a day apart, so there's individual testing sessions. Then they cross over their stabilization on 0 milligrams of abutolast, then the same testing sessions, and then they're discharged. So this study had 11 completers. They were all male. 45 years of age, average. They similar use pattern as the other studies that recruited opioid-dependent participants, using about 6 bags of heroin a day. Again, that's about $64 a day of heroin. Mostly intranasal users for this study, and all of the participants reported heroin as their primary opioid of choice. There was just one who had a preference for, I believe, snorting oxycodone. So what we're looking at here are subjective effects. So again, that 100 millimeter line appears on the screen asking how much do you want heroin on. So on a scale of 0 to 100, they selected wanting heroin at about 45 across the doses. There is a significant effect of a butylase maintenance for all 3 dose conditions. So it was lower for participants randomized to active abutylase, when participants were on active abutylase. Sorry. This effect also for wanting of cocaine is statistically significant for the 15 milligram dose, and wanting of tobacco for the 15 milligram dose as well. So we see a dose-dependent effect of how much participants reported feeling high in response to the oral oxycodone. However, there's significant effect of a butylase maintenance. Similar for like the choice, a dose-dependent oxycodone effect. However, for participants, when they were on the active abutylase, oxycodone liking is lower, and it's statistically significant. It's trending for would pay, but again, not statistically significant. What I'm showing you now is the breakpoint as a function of each of the doses of oxycodone. So participants, when they are in the placebo condition, there's a dose-dependent oxycodone effect, which is somewhat attenuated for the 15 milligram oral oxycodone dose. However, it's not statistically significant for the difference between the two isn't statistically significant when participants receive 30 milligrams of oral oxycodone. So from that, we concluded that under the active abutylase condition, drug liking for the 50 milligram oxycodone condition was decreased significantly. Also, the self-administration for the 15 milligram condition was decreased significantly. However, no effect was observed on those measures for the largest oxycodone dose that we tested. Heroin craving was also significantly reduced, and some similar effects were observed for tobacco and cocaine. So what I'm showing you here is a few of the studies that have been done with glial modulators. The 2 studies that I told you about, we did a pilot clean that was then followed up by the group at Yale. Ours showed some significance, but theirs actually didn't on any of the drug-related measures. So most of the studies with our group have, so our group has done most of the studies with. However, there has been a lot of work done with psychostimulants. A few different studies have been done with cocaine, methamphetamine, with abutylase and minocycline. Some studies have been done with pioglitazone, showing a significant effect on drug craving. I think one of the most interesting ones that should be followed up on with respect to opioids is the effect with N-acetylcysteine. Several studies have shown positive findings with psychostimulants. A few studies have been done with alcohol. by Laura Ray and Dr. Petrakis. And there have also been some studies with nicotine and cannabis, just to sort of show you the breadth of the data. So in conclusion, glial cells are influenced by drugs of abuse. The interaction contributes to their acute and chronic behavioral effects. The involvement of glia in the development and maintenance of substance use disorders may have important implications for the development of novel pharmacotherapies, particularly this non-neuronal pathway. But I think there's a lot that we don't know about how these two systems interact, particularly with respect to sex differences, acute versus chronic effect that drug abuse have on glia and neuroinflammation as a whole. So the clinical studies have shown promising results, but they haven't been as robust as the preclinical data. One of the things that was a significant barrier to all of the studies that I'm telling you about is this sort of proof of concept with the medications that we chose and the dosing. We are limited by the doses and maintenance conditions that these drugs are approved for. So how that translates to this is unknown. So even though the studies that I'm telling you about were largely negative, I think there are significant limitations that still that make us believe that maybe if we go back to the drawing board, looking at what we might need to do to actually get a significant effect on glial modulation and show that as our proof of concept before we demonstrate anything, then we may be able to then go back to the clinical laboratory and retest some of these medications at sufficient doses. At the time, the thought was that peripheral glial markers didn't. NIDA and the drug company that funded one of the studies weren't convinced that just using peripheral markers of glial cells wasn't going to tell us what's going on in the CNS, so they didn't want to pay for the expense of looking at those. And I think a lot of that thought has changed now, and that collecting data on peripheral markers would have probably been a great idea for a lot of these studies. Again, there's a lot of the preclinical studies, so sexual dimorphism, which we weren't able to explore. With our clinical laboratory studies, we typically have very poor female representation because of their duration and being inpatient for such a long period. So that was something that we can address as well. So this is the group that we work with. So everyone here is great. Sandy's the head of the lab. So most of the funding she received from NIDA for one of the R1s. And the other was some studies that we conducted on our old medications development P50. So this is the group and nurses, MDs that help to get the job done. So with that, I think I am done and we can open it up.
Thank you, Jermaine, for a great talk. So let me remind the audience, if you have questions, you can type them into the Q&A function. And if you're having trouble, you can just chat them to us too. There's an option to chat the panelists. So feel free to do that. So as folks get familiar with the function, let me, I had a few questions myself. It's really intriguing. I think on multiple levels. Maybe I hate to ask the broad questions first, right? Because usually you like to focus on the nitty gritty details, but I think I'll ask a broader question. So, and then kind of we can zone in as well. But so Jermaine, I think for those of the members of the audience who may not be familiar with kind of like the early clinical trial testing that you do in the human lab, right? Where there's drug self-administration, there's drug administration and subjective effects. If you could explain a little bit about the power and why it's such a robust and important thing for us to do as researchers before we move to these very expensive multi-million dollar clinical trials that require very large sample sizes and whatnot. But just for those folks who may not be familiar with, us doing this research in humans, if you could talk about that, that would be wonderful.
Yeah, so I think where we often lose a lot, so I think the external validity of these models has been pretty well established. So showing that a medication that's able to reduce self-administration of a drug in the clinical laboratory, this is then going to function very well in a large-scale clinical trial. So exactly like you said, our studies are proof of concept studies in looking at direct medication effects on how much it can reduce drug craving, or in response to drug cues, because in the real world that's what happens. Participants or individuals get exposed to drug cues which elicit craving, and then they subsequently go on and to use. Also, our self-administration paradigm has sort of the constructability in the sense that this is the choice that drug users make. You have to choose between this amount of money that you have and between a drug review. So I think our studies are a great way to screen potential medications, like you said, before they go on to these large scale clinical trials. So we typically, our sample sizes, I would say, hover around 12. Sometimes we can get away with publishing as little as 8, but still, they have such significant external validity that I think it makes them a really necessary step. And also, a lot of the times, this might be the first time that this drug is being tested, not only for this indication, but also in the target population. So if there are going to be any safety concerns that arise, it's best that that happens in a controlled clinical laboratory setting.
Right, like potential interactions between the addictive substance in combination with the medication, right?
Exactly.
Yeah. Well, thank you. So we've had some questions come in. One is from Carol Hubner. Sorry if I didn't pronounce your name right. But she asks, have there been preclinical studies following chronic administration that would suggest that human efficacy studies will be more promising with chronic administration?
So was the question if there have been preclinical studies of chronic administration?
Let me, I think I can allow Carol to talk. I'm gonna,
Yep.
So Carol, can you talk?
Can you hear me?
All right, yeah, we hear you, yeah. Go ahead, please you'll ask your question way better than I can.
Sure, thanks. Well, it was a very interesting talk. One of the things I was struck with was that the measures of efficacy were not necessarily dose dependent, which in my view often is of concern. But I was wondering, because most medications that are going to be given to this subject population will be chronic, that it might be that the modest efficacy that you saw in your studies might be just indicative of the fact that they were administered acutely. And you did talk about the lack of concurrence between the preclinical and the clinical studies. And so I was wondering, are there preclinical studies where they've given any of these, compounds that, affect the glial system? If they've been given be given in preclinical models following chronic administration, and whether that might suggest an even greater effect that could then be translated to your human laboratory studies.
Thank you.
Yeah, that's a great question. So yes, so typically preclinical studies in how long they can have their subjects receive a medication. Like I said before, we're often limited to not only the dosing parameters of the approved indications, for what there's safety and efficacy data on. So we, in our studies, are basing, crossing our fingers, hoping that, pioglitazone takes about 14 days for diabetes, treatment of diabetes. It takes about 14 days before you see an effect. We're crossing our fingers, hoping that that's sufficient to get an effect on glia, without any other, the data haven't been shown that was sufficient for maintenance on this. So, it's definitely a translational concern. But, it's one of those of research that we do. I think it's definitely possible that with chronic administration, we'll see an effect. We could potentiate the effects that we saw. And I think if there was sufficient interest in funding, an 8-week study from the powers that be, combination with, it's always feasibility as well. So funding and feasibility as well start to come into play. But yeah, it's definitely a possibility.
Thanks. So Dr. Erica Groden from UCLA, I think if you're still there, Erica, I don't know if you've updated your affiliation, but I've allowed you to talk. If you'd like to ask Dr. Jones your question.
Sure, can you hear me?
Yeah, thanks.
Okay, great. No, I'm still at UCLA. So I work with Dr. Ray on some of these ibutolol studies. So I was curious if you were seeing any side effects with any of your medications. I know in the alcohol field, there's been a lot of issues with pioglitazone. So I was curious if that was influencing any of your results, or if you guys were just able to get it through without many side effects.
I don't recall a significant number of AEs in the pioglitazone studies. So at the time, you all probably experienced this as well, but studies, risperidone was simultaneously pulled off the market by both the FDA and their European counterpart. So we're submitting an IND to study pioglitazone in these populations just as this is happening. So we had really, really strict, the FDA gave us really strict safety criteria just for enrolling participants. So we were we found it really difficult, and we were looking for unicorns among substance use disorder patients who have their health is superb. But yeah, I think that was the case in that we probably didn't see that many AEs because of that.
Okay. Well, thank you. Well, with that, it is now 2 o'clock, so we should let everybody get to their next Zoom meeting, but I hope you enjoyed it. I found it very, very fascinating. Thank you, Dr. Jones, for your wonderful presentation, and I look forward to meeting with you one-on-one after this.
Yep, sounds good. Thank you, guys.